Williamson. I'm the Executive Director of Scleroderma Society of Ontario. And Scleroderma Canada and all the provinces across Canada in 2021 are hosting different information series nights and days. And Scleroderma Society of Ontario is hosting today's talk dealing with COVID and vaccines. And so the series will be going on throughout 2021, and you'll get updates on both websites regarding our next one in March. So without further ado, I'd like to begin this series by turning it over to our moderator, Dr. Brett Toombs, who's a good friend of ours and probably a good friend of many of the people that are on this webinar who know him very well. Dr. Toombs is a professor of psychiatry at the McGill University in Montreal, Quebec. He is the senior investigator of the Lady Davis Institute for Medical Research at the Jewish General Hospital in Montreal, Quebec. And he is the founder and director of the can't even say it now, Scleroderma Patient-Centered Intervention Network, which we all know as SPIN. So without further ado, I'll turn it over to Dr. Brett.
Great, thanks, John. Thanks to everybody for attending today. It's exciting to have another one of our panels here. And thanks for Scleroderma Ontario for hosting this great panel. We're very fortunate today to have a wonderful set of panels with us today, who I'll introduce in just a minute. Just a brief note on the format. So we will go through. Each of the panelists will give a brief overview of their topic. And then we'll take questions. That's really what the primary intention is, to take questions. We have a number of questions that were submitted ahead of time, which I have here and I'll present to the panel. You're also please welcome to add questions as we're going along, either as somebody's speaking or general questions and so forth. Please put your questions in the chat, and I'll pick them up in the chat, and I'll ask the panel as we're going forward. So don't be shy, and any questions you have would be great to share. So our first panel, we'll go through. We have several panels here. Welcome to Marc Larcher. Marc is an immunologist and professor of medicine in the divisions of clinical immunology and allergy and respirology at McMaster University in Hamilton. He holds the McMaster University GSK chair in lung immunology at St. Joseph Healthcare. Marc is going to discuss generally viruses and how vaccines work, including the COVID-19 vaccine. So we have a little bit of background information on that. We're very fortunate to have John Varga with us, a good friend of all of us from the States at the University of Michigan. John is a rheumatology division chief. He earned his bachelor's at Columbia University, his MD from New York University, just 5 years ago. It's been really a quick transition. John does translational work on scleroderma fibrosis and is known for his work in defining TGF-beta mediated fibrosis. John has a passion for education. He's mentored trainees at all levels. Several have gone on to develop successful careers. And John's a great friend to SPIN, and has really added a lot to us. We're really fortunate to work with John. John, I should point out that as we'll discuss here, there's some great resources for people with scleroderma. The Scleroderma Foundation has had some nice recommendations and questions and answers, and John was part of their expert panel to put those together. There are also fairly similar recommendations for patients with autoimmune rheumatic diseases from the Canadian Rheumatology Association, which are out there as well. And Janet may have something to say about that. Janet Pope will also join us. Janet is a professor of medicine in the Division of Rheumatology at the University of Western Ontario in London. She's also the division head of rheumatology at St. Joseph Healthcare. And finally, Maureen Salve, another good friend of ours. Maureen and I have been working together, gosh, for 10 or 12 years now, in setting up SPIN and moving a lot of our activities forward. Maureen is Vice President, Advocacy and Public Relations with Scleroderma Canada, and an active patient advocate. So back about 20 years ago, this Scleroderma Ontario was still, or Scleroderma Canada was still part of the Arthritis Society, and I think wasn't really scleroderma focused and specific. And Maureen was the one who spearheaded setting this up as an independent registered charity, which I think laid the groundwork for much of the really tremendous work that these groups do for people with scleroderma here in Ontario. So Maureen's spoken as a patient rep at medical and educational conferences and events around the world, and she'll be talking about patient perspectives on some of the questions that come up today. So without further ado, we'll turn it over to Mark for his brief overview on virus and vaccines in the context of COVID.
Okay, thank you very much, Brett. I'm going to share my screen with you here. And I'll just set the scene, as Brett said, a little bit of information about viruses and vaccines that is going to be relevant to the discussion. So first slide really is an overview of how vaccines work very briefly. Vaccines are designed to stimulate our immune system, of course. And the major components of the immune system that are engaged by vaccines are two groups of cells, the B cells, which are the cells that make antibodies, and T cells. And in this particular case, in terms of immunity to virus, we're talking about what we call killer T cells that have the ability to kill a cell in your own body that is infected with the virus as a way of limiting the spread of the virus. So key features of the immune response in this context include the fact that we develop immunological memory. So in other words, when we see an organism, our immune system sees an organism, we remember that and we can respond more rapidly to that organism second time around. And just to say that the immune system recognizes shapes essentially, and remembers shapes, the shapes of proteins in particular that are foreign to our body. So I like to make analogies or draw analogies when I'm explaining immunology. And so here's a military analogy for antibodies. And so I think of antibodies as the infantry because these are the guys that are engaged in hand-to-hand combat. We make many, many billions of these things every day if we're infected with a virus or if we've been immunized with a vaccine. And essentially these antibodies bind on a sort of one-to-one basis with viruses and bacteria, etc. So they do the hand-to-hand combat, and thereby they neutralize the threat. So you'll have heard of neutralizing antibody responses. They neutralize the virus by binding to the outside of it and stopping it from doing the things that it likes to do, which I'll explain in a second. So the military analogy with killer T cells is that they're a bit like tanks and they like to blow things up. And essentially their job is to take out the factories that make the weapons, weapons by which I mean the viruses. So on the bottom left there, you'll see just an electron micrograph of a small part of the inside of a cell. And all those highly organized tiny black dots are viral particles that have been manufactured in the cell. So the viruses take over the cells they infect, and they use the cell's machinery to make copies of themselves. When the cell gets completely full of copies, the cell bursts and releases, millions or billions of viruses. And so the killer T cells have the ability to take out these factories and protect us. So here briefly is a picture of the virus. You've probably all seen this. I'll just get a little pointer going here. So here we have the RNA inside the virus. Our cells use DNA and RNA. This particular virus uses RNA. There are a variety of proteins inside the cell, but also on the surface of the cell. And this one in particular in orange is called the spike protein. I've shown it here on the right. The spike protein is the major target of all the current vaccines. This protein is involved in allowing the virus to enter the cell. It binds to receptors on our human cells, initially in the airways, and allows the virus to get into the cell. So spike allows virus to get into the cell. So here's a cartoon of a host cell expressing a receptor molecule. This is a protein on our cells called ACE2. And the spike protein on the surface of the virus is able to bind. It recognizes the shape of this receptor, it binds to it. And then that allows the virus to sort of merge with the membrane of the host cell and cause an infection. Now, antibodies to spike can prevent this, and the purpose of our vaccines, or one of the purposes, is to induce an antibody response. So if you get infected with the virus, your B cells make antibodies. Some of the antibodies are targeting this protein. If you get a vaccine, the same thing happens. Your immune system targets the protein. And what you have here is an example of an antibody that's bound to part of the spike protein. This RBD is receptor binding domain. This is the bit that engages here with the cell receptor. And basically this blocks this interaction here, so the virus can't get into the cell. If viruses do make it into the cell, then the killer T cells take over. Here you can see one. It's just about to administer the kiss of death to this virally infected cell. So just to finish up, here are the current platforms that are available. On the left, we have the sort of classical, or if you like, old-fashioned platforms for viral vaccines. And on the right, we have the next generation platforms. Most of the new vaccines are next generation or more modern. Here we have Pfizer and Moderna, the only two that are approved in Canada, and they are examples of RNA viruses, which we can talk about later. AstraZeneca will soon be coming online. This is a DNA, it's a viral vector, a different kind of virus that's been inactivated, but can deliver a payload of SARS proteins. There is some Canadian interest. Diosvax, a UK company, will be doing clinical trials soon. McMaster has a vaccine in development, and Providence, based in Calgary, also have mRNA vaccines. So there is some Canadian interest, and as you've heard in the news, an appetite to develop or produce some of these vaccines in Canada. So we can discuss those as well if you like. Finally, potential problems that you'll have heard about and we can discuss. Antibodies to coronaviruses don't last forever. It is possible to be reinfected a year or perhaps more after the original infection. It's probably with a slightly different strain of the virus. There are mutations that we're seeing, South African variant and UK variant, Brazilian variant, etc. These mutations in the viral genes change the look of the proteins on the outside of the virus and therefore evade recognition by the immune response we may have already made to the earlier virus. And then finally, all of the frontline vaccines, the ones that are online now, focus solely on making immune responses to spike, which although that helps with producing the vaccines quickly, it limits, potentially or theoretically limits their efficacy long-term in the sense that we're only relying on immunity to one protein. So some of the vaccines that are coming online later have focused on several proteins. So there you are, that's a background, whiz through the background, and I'll stop sharing now and we can move on.
Great, thanks, Mark. That's a tremendous introduction. And welcome, Janet, or you're me now, as I screw things up further by sending you my link apparently. But welcome nonetheless. Good to have you here. And let's move right along to Dr. Varga, who'll be talking about recommendations on the vaccine.
Well, thank you very much, and really a pleasure to be here with everyone. We did this about a year ago, and boy, that's been an interesting and challenging year. But we've learned a lot. I think, in terms of scleroderma, a couple of issues come up, and this is what patients typically ask us. So one is, how does the disease impact on people who have scleroderma? And those questions tend to fall into two categories. Are you, if you have scleroderma, more likely to get infected than somebody without scleroderma? The second one is, if you have scleroderma and you get infected, are you more likely to have a more severe disease or a worse outcome or greater risk of hospitalization? And the second set of questions, which is a newer set, of course, is vaccination. Should people with scleroderma get vaccinated? And I think the answer to that is absolutely yes. So we can move past that quickly. But the two issues that I'm sure we'll come back to relate to, is there any risk of your condition getting worse or flaring up or progressing as a consequence of getting vaccinated? And the second question is, if you get vaccinated, are you more likely to have a muted or inefficient response compared to someone, who doesn't have scleroderma? And we'll come back to these, but just to set the stage, I would really say that we actually have very little data. So even though there's been an avalanche of publications, studies, data sets in the past year, one has to be very careful at looking at the data, and there are a lot of holes in it because none of these were really done as very carefully constructed and well-designed studies that normally would take a longer time. In terms of the first question, though, my brief comments, and I'm sure we can come back to this more granular, there's really no compelling evidence that people with scleroderma are at a higher risk to get infection than other people. There are some studies that suggest that, but they're methodologically flawed. Having said that, though, I think a very important point is that it's very likely that people with scleroderma, when they do get COVID, are at a higher risk to get more severe complications, be it just feeling sicker, ending up in the hospital, ending up requiring intensive care unit care. And so that's kind of what was expected. And I think the data we have to date sort of supports that. Now, moving on to the vaccination part, again, I think no one really would strongly disagree that people with scleroderma do need to be vaccinated whenever and however it's possible and feasible, for the reasons that I mentioned, which is that if you get COVID, there's a risk of getting more ill than people without scleroderma. There is very, very little, if any, evidence, to my knowledge, that vaccination with COVID with the currently approved or currently used therapies can make the disease worse or cause a flare-up. Very common concern, but there's little, if any, data to support that concern. A much more pragmatic and realistic concern is that if you get vaccinated, are you likely to have a good immune response the way Mark just explained that, or are you going to have potentially an insufficient response? The disease itself probably does not mute the immune response, but the medications that people take potentially could. And I think we might perhaps get into a little bit of detail as we go along. Again, a lot of it is not supported by strong data. And I would really call your attention to the American College of Rheumatology COVID website. The American College of Rheumatology has had a very strong task force that really for the past 4 months or so worked relentlessly and tirelessly to look at all the available evidence of how to manage medications in people with scleroderma who are going to get vaccinated. And there's a very detailed and reasonably strongly evidence-based analysis, and you can look at it on the website. It's publicly available, which gives guidance to physicians as to which medications is it safe to continue. By and large, most of them or many of them are, but some probably should be held for a period of time. And again, it's very, very important to discuss all of these with your physician, even if you see a clear recommendation on the ACR website as to what's the best strategy. So I think I'll stop there, and I'm sure there'll be more specific questions regarding these issues, and I'll turn it back to Brett.
Great, thanks. Well, we'll move it right along to Dr. Pope, who is going to talk a little bit more about some of the concerns that have come up from patients and what those recommendations tell us. So,
great, thank you. And first of all, thank you everyone for attending. We've got almost 100. We're going to crack 100, I think, any minute. So there is a lot of interest here. So concerns that patients may have in the recommendations. So one concern is which vaccine? And I think the easiest answer is whatever one you're offered, because we won't have control over who gets what. And the two that are approved, and probably one will come in the near future, are all fortunately highly effective. Another concern is, well, should I get a titer? Because I think I had COVID when we weren't testing way back, say in April, where I didn't travel, but I think I got it. No, you shouldn't get a titer. The recommendation of all the vaccine agencies are just mass vaccinate where possible so that we can get herd immunity. And also because you heard earlier, like Mark said, it doesn't always, you might not have immunity indefinitely anyway. You probably won't to any vaccine have immunity indefinitely. So just get vaccinated. Another question and concern, I think, from patients that they've asked me to date is, once I get my first vaccine, what if the next one's delayed? Because, there have been delays already for some of our highest risk patients. And the answer is don't worry. So just like, if you've had the shingles vaccine, it's one dose. The next dose is in a month to 6 months later, things like that. Usually you get a pretty good response after your first dose. So if your second dose comes late, you shouldn't worry. And you will still continue to have, hopefully, that decent immune response for a long time. So the timing isn't as important as you think it might be when it says, well, when we take a med, it's prescribed at a certain time. For the vaccine, it's enhancing the initial immune response you get. Another person has asked me, can I get COVID from the vaccine? Absolutely not. This isn't live. It's that it's the mRNA directed at that one coronavirus, the spike protein. So you can't get COVID from it. You can get a fever or achiness from your immune response. And some people have told me, at least that have 2 shots already in, that sometimes the second one, they're more achy, but not necessarily. What if I'm allergic to other vaccines? So this doesn't have albumin from eggs or chicks in it. There's no worry in general of allergies, and really in the groups in whom it's approved. So not kids under 12, or in some jurisdictions under 16. And I won't speak fully to pregnant moms, although the OB-GYN Society of Canada said they too should be vaccinated. So aside from some groups where I can't give as much data, I'm not as knowledgeable, there's really no contraindication. And the only thing a patient did ask me is, I did have one patient, I'm talking a patient with Guillain-Barré that is a known but very, very rare risk after the flu shot. My patient who got Guillain-Barré didn't have a flu shot that gave it to him. He just got it from whatever reason. And so he asked me, is it safe to get the COVID? And I really told him, I'm not sure, so I can't answer that. But short of that, I can't think of any reason why not to get the COVID vaccine. So they are some of the things. The other thing is the recommendations are ever changing. And for instance, I know we're a Canadian group mostly here. The US recommendations from the American College of Rheumatology, for instance, that just came out on what drugs to hold, literally came out the last few days, and that's on the American College of Rheumatology website, are different than the British recommendations that say don't hold any drugs, just get your arm out and do it. And our Canadian recommendations are somewhere in between, suggesting that some drugs you might hold for a couple of weeks and other drugs you probably don't need to hold. So I think, as Dr. Varga nicely put it, please discuss it with your treating physician. But in general, unless if there's a reason not to get the vaccine, we hope and think everyone should get it. So I will stop there.
Great. Thanks to everybody. So before we get into the questions, I did want to point out one thing that Dr. Pope mentioned. So she did mention there's a discordance between different groups of supposedly smart people, right? Who are all saying somewhat different things. So why might that happen? So, it's not turf war, and it's not because some people are smarter than others usually in these cases. I think usually when people like this, these are all great groups, when they come together and they have somewhat different recommendations, it's because 2 things are going on. There's not super clear evidence, and it doesn't matter a lot. I mean, usually if there's clear evidence that people are getting benefit or getting harmed by something, the guidance across different groups, whatever the condition or whatever the service, tend to be pretty concordant. When they differ like this, it's usually, again, because, it's a judgment call, and what it's uncertain if it's going to affect the uptake of the vaccine or not to do with your medication. It's not that clear, so it's probably not a huge hammer up there on anybody, and people might make different decisions. In the end, when there's different reasonable decisions to make, like Dr. Pope mentioned, talk to your doctor. Figure out what's most important for you and what might occur, and have that discussion with your physician. So please, to all the people in attendance, go ahead and type in anything into the chat if you get any questions. I want to go over a lot of the questions that we have that came in earlier have been answered by the panelists, but I wanted to come back to Dr. Varga. So you mentioned this, John, that you said there's little data to support the concern that getting the vaccine can kind of produce an immune response and put someone in worse shape. When you say there's little data to support the concern, does that mean that someone shouldn't be concerned about that? That it's not realistic to think that or worry about that? Because that's a question that came from a number of people.
I think that's a great question. I think based on prior experience with vaccinations, it's really tends to be isolated, anecdotal cases of people, other than the rare exceptions that Dr. Pope mentioned, people feeling that their disease got worse. And particularly a chronic fibroinflammatory condition like scleroderma would be very unlikely. Patients can certainly report that they have aching and pain, and in a way that's probably a sign of a good immune response to the vaccination. But I'm not aware of any credible case reports or evidence of anyone's scleroderma flaring up or kicking into high gear or being activated as a consequence of vaccination. And so I think it's fair to say that the benefit vastly outweighs the risk, which is strictly hypothetical at best.
Great, thanks. And so I want to come back to that because that point came up, and then I want to go to our last speaker. So Maureen Sauvé.
You're muted, Maureen.
Apologies. As patients, we spent most of the last year in varying degrees of isolation and have been anxiously awaiting the development of vaccines. And yet we know that the general population has some real concerns about the speed with which these vaccines were developed. KPMG released a survey that they sponsored in December of 2,000 Canadians that found that 47% of Canadians didn't think the vaccine is safe to take, but most, 81%, would take it anyway. So the question comes about, if there's that much concern in the general population, what does that mean for us as scleroderma patients? You've answered many of the questions about how our patients have fared. Do we know how many scleroderma patients have had COVID? Were their responses particularly bad? Did many end up in the ICU? These are factors that weigh into people's decision making with regard to whether there's a risk involved or what the benefits to the vaccine itself are. And certainly lots of questions about what kind of drugs we should or shouldn't be taking, because when you're suppressing your immune system and you've got this virus going around and you're intentionally causing an immune system reaction, is this where the problem and the concern is in the medical community? But when we talk about all the uncertainty, the one thing I know as a patient is that as individuals with a rare disease, we're probably more accustomed to dealing with less robust scientific evidence in the drug development world than others. I mean, after all, when you consider how reasonable is it to test medications for rare diseases in large populations, it's not possible. So the question marks surrounding the vaccine and its speed don't concern me. I'd have been far more concerned if they were so conservative that we would still be sitting here 2 and 3 years later waiting for perfect evidence before they rolled the vaccines out. But given what appears to be significant disease burden, if you'll use the term, if we are to contract COVID-19, if we are more likely to end up in ICUs or on ventilators, then that would certainly sway my decision to take a vaccine. And so I pose that question to the doctors in helping us as patients become better educated and understanding what the risk-benefit ratio actually is. And finally, as you've said, certainly everybody wants to know, and it was one of my first questions, with all of these various types of vaccines being developed, in a perfect world, if there was one we should take, if we had a menu option, which ones probably would be most appropriate for people with immune system issues? Or alternatively, which ones would be the ones you would be hesitant to take? And thank you, Janet, for saying the ones we already have available are good. That is a relief. So choosing A to B here is, as we're aware, we'll be lucky to have a choice, as in, can I get one, not which one can I get? But there may be a possibility further down the road that there will be choices. Not that I personally would wait that long. I really want to see the outside of my home. I'm a little tired of being isolated and would like a little less risk. And I think many patients fall into that category. So on behalf of myself and the other patients on the line, I'd really like to thank all of our docs for taking the time to help us make these decisions. So I'll turn it over to you to answer those questions if you can.
So what is, thanks, Maureen. Those are a lot of good questions here, and I'll let people get to different ones. Well, maybe why don't we start? What is a risk benefit? You know, whenever you do any kind of healthcare intervention, there's good things that happen and potential bad things that happen. And what are the risks? What's the risk benefit profile here, if you had to think of it that way? So either anyone who, Dr. Varga, Dr. Pope, anyone else, Dr. Lachey? Yeah, go ahead, Janet.
Okay, so I mean, again, each person will weigh this differently, but in general, if you think of the other vaccines that will help to decrease the chance of disease, that is infections that should be treatable, like when you get your shingles shot or when you vaccinate your kids, things like that. So we know the benefit of the COVID vaccine, and to really touch on Maureen's point, the COVID vaccines so far that have been approved in Canada have high benefit. We're really lucky. They're actually more effective than a lot of other vaccines we have, like the polio or pertussis, as a for instance. So high benefit. And we actually know the risks. So they were studied in as many people as any other vaccine that would come to market. So we know the risks because almost all risks of vaccines are early. So sore arm, a weird side effect, anaphylaxis where you can't breathe or something like that. So we know the risks, and there are some risks, and they are present, and they're actually very low. This is a very safe group of vaccines to date that we have access to. What we don't know, and that's where Maureen said, you know, I'm glad that it's out quickly, but if people aren't believing that it's safe, what we don't know, and this is what Mark also mentioned, is the long-term benefit. Will we need in a year to get revaccinated, like the flu shot where we get it every year? Will we need to be revaccinated as mutations occur, and perhaps our natural immunity will also wane? So the benefit is upfront to decrease the chance of COVID for yourself and others around you, and to get enough people vaccinated so we can return to some semblance of less social distancing. So that's the benefit. The risk is you don't know if it will flare your disease. I think that's highly unlikely. And why do I say that when I don't have a bunch of scleroderma patients vaccinated yet? I only have like some high-risk healthcare workers in the nursing home with scleroderma, 1 or 2 in my practice that have been vaccinated. But I think, again, we know that the shingles vaccine, the more recent one that came to market, which is the Shingrix, is highly effective and sets a very high immune response of gamma interferon, and that this vaccine, the COVID vaccines that are available in Canada, will have probably a similar reaction, in a good way, reaction to get an immune response. And we didn't see on the shingles vaccine, which is totally different, but has a similar way of perpetuating the immune system to get revved up. We didn't see a lot of flaring of diseases for years now. It's been out in Canada. So I think the benefit is known. Decrease the chance of COVID, decrease the chance of severe COVID, and decrease the chance of spreading COVID. They're the benefits. The risk is, will I get a side effect up front? Will it flare my disease? Or will I not be a good enough immune response so I go about my daily business and then I get COVID? So we do know that after a large population of Canadians are vaccinated, that we'll still have to wear masks, we'll still have social distancing. Why? Because they'll want enough people vaccinated mounting a good enough response. And because by then we'll know in the original trials how good is the immunity, because all the people when these drugs got approved that were in the trials have still consented, if they're willing to get blood titers done to see how long it lasts for. So by the time all that's ready, we will know more risk of how long does it work or doesn't work, but we already know the benefits. So that's how I would weigh it. And I think that each time you discuss with your healthcare providers, you'll get that kind of, here's the upfront benefit, pretty safe, pretty effective. What risk is it to you? Well, what about flaring my disease? What if I don't mount a good enough response? And what if I go about thinking I'm vaccinated effectively and I'm not? I think that's how you would probably end up looking at it.
Great, thank you. So I'm gonna, as I'm going through, I'm trying to summarize some of the questions, and between what Marina's put forward, between what came in earlier, what's coming in now. And if I've missed something important, please go back in the Q&A and go ahead and put it there again. But there are lots of questions coming through about drugs and medications, and if you want to, in Canada, are there specific drugs where people are saying you might be seriously consider holding this? Maybe it's a personal decision to talk about, or maybe there's no reason to consider holding this. Can one of you talk about which medications might be fit in some of those categories?
Well, I would really recommend two things. One is reference to the ACR website, because this task force really spent enormous amount of time every single drug that we use and looking at all the evidence based on COVID and other vaccine experiences. But the other thing is that really try not to really make a unilateral decision, because there are a lot of complexities here. Always the issue of risk and benefit. And really, I think your physician is probably the one best suited to make an informed recommendation. Generally speaking, again, very generally, many immunomodulatory drugs are reasonably safe to continue, but some are not. And in particular, for example, we know that rituximab, which is not approved for scleroderma, but is not uncommonly used, probably should not be given in close proximity to the vaccine, because it might really mute the immune response to the vaccine. Possibly drugs like methotrexate and cyclophosphamide, and some of the newer drugs are also ones where it's likely that giving a drug-free holiday for at least a couple of days might help you be able to mount a better immune response, which is the whole purpose of getting vaccinated. So there are some subtleties, but again, you always have to weigh the risk and benefit, because if the risk of being on a drug is very small and the risk of stopping a drug is high, then it's a different equation. So I think it's something that needs to be done very thoughtfully. Jana, do you have a similar approach to that?
I do indeed. And again, mostly what we're doing is comparing to, so there are a large class of drugs that actually isn't common in scleroderma, systemic sclerosis, but is very common in patients with rheumatoid arthritis, and some of you that have an overlap with significant inflammatory arthritis. The TNF inhibitors, that's the etanercept or the infliximab or the adalimumab, those kind of drugs, they don't seem in past studies of the flu shot or the pneumonia shot or the shingles shot to dampen the response to it. But that's not a large group of drugs used. And where we might think where people might get a poor response is high dose prednisone, corticosteroids, glucocorticoids. And most of our patients aren't on, with systemic sclerosis, aren't on those. Whereas if you have dermatomyositis or polymyositis overlap, maybe you are. So, and that would be not unsafe. It's just we don't know that you'll get a decent enough response. So that would be my approach as well, as you kind of look at other data. I like that ACR website, and it is in the chat. Everyone can cut and paste that link later if you'd like. Brett nicely put it in the chat to everyone. So I think the bottom line is what I've told patients today is here's what I suggest, but it looks like in Canada, it's going to go by age after the long-term care seems to be nearly done, at least in Ontario, that it'll go by age, the over 85 living independently, then the over 80, then the over 75, etc. So it doesn't look like it's going to be, oh, those with immune diseases at higher risk or lower risk or equal risk go first. It looks like it's going to be an age thing other than the healthcare workers that will get loaded up front. And then some other first line workers. So whatever I tell people now, I realize it's really easy to forget. So I've taken upon it myself to write a note for you and your drugs. Every time you hold drug X, you seem to flare in under a week. Maybe for you, you don't hold drug X for this, even though guidelines might suggest drug X, say methotrexate, should be held for a week or two. Maybe you don't because you always flare, as a for instance. But I've also said, if you lose the sheet or forget, don't worry, because it's not the end of the world. We have people vaccinated every day who haven't held drugs that do of all sorts of diseases to do just fine. So that's how I would don't dwell on it. I think the bottom line is some response to vaccine is better than none.
Well, Janet, that's a great example you gave of why for one particular person they may or may not hold, depending on what happens when they stop their drugs normally. And I want to come back on that because we keep coming back to the idea of speaking to people's doctors about this. So are there any other examples to help people understand why there might be different decisions made for some, why we can't just give a blanket answer? Why might the decision to hold drugs be different for some people than for other people? And I think that's something some people are wondering about.
I think it's the interpretation of the data, because our types of patients were not in the randomized trials. We can't say, oh, if you didn't hold your drugs, you'll get just as good a response as the general population. So because we don't know those kind of data, and we'll probably know them by the time revaccinations will occur in a year or 2 years or whenever that might be needed, we might know more from ongoing studies of observational studies going on. And then it is the interpretation of the data. So an individual, if people are very sensitive to holding drugs and flaring, then I'd rather they don't flare, because we're trying to do benefit, not harm. And then I also look at guidelines. If the British Rheumatology Society says don't hold anything, I think they just did it to make it simpler for people to just get the job done, because a lot of times you won't have a choice when you're going to get your vaccine. It'll be on social media that this age group and this community is next, sign up. So you won't have a lot of chance to maybe reach your doctor. So that's why I think guidelines are just that, as we mentioned earlier. They are guidelines, and that I think what's more important is that we get enough people vaccinated, get herd immunity, and get you yourself vaccinated so that you have less chance of getting the disease, COVID, or getting a serious version of the disease. And whereas if you hold a drug or you don't hold a drug, I think is more like icing on a cake, but we need the cake first.
Yeah, I would just also comment that in the United States, the CDC guidelines do recommend that people with autoimmune chronic conditions get prioritized. And so the American College of Rheumatology included that rheumatic disease patients with or without immunosuppressive therapy should get prioritized. But in reality, a lot of these decisions are made at the state level. And from what I've heard, it's been a tough sell, because states seem to be allocating, at least right now, the vaccination pretty much based on age initially. And so many patients ask their doctors to write letters and so on. And I think that's perfectly reasonable, but there's no guarantee that that will let you get ahead in the line. It's sort of a very dynamic and fluid situation. So, yeah.
Right. And I think just to add on this, and I think Mark would agree from the immunology background, is that for COVID, age is by far the largest risk factor of poor outcome, not of getting COVID, of poor outcome with COVID. And then heart disease and including high blood pressure and obstructive lung disease and diabetes and high dose prednisone. But age in every study is the largest risk. And I think that's why with respect to equity, why a lot of public health agencies and states and provinces and municipalities are going forward by age, because I heard someone say the other day that seems to be very smart on vaccines. So it's not someone in the development, but someone from one of the vaccine companies said that a healthy 82-year-old will always have a higher risk of bad outcome with COVID, even though they might not get bad outcome, but a higher risk of bad outcome with COVID than a very sick 50-year-old on chemotherapy. And that like just hit me. It's like, oh my gosh, I would have thought the person on chemo, because that's such huge immune suppression. So age is such an important risk. And that's why I think for equity, they're trying to get, at least in Canada, age, and the highest risk are people institutionalized with age, and then also the marginalized communities, because it can spread like wildfire in those communities as well, including the homeless, including isolated communities up north where one person brings it in because maybe they traveled to somewhere like Winnipeg, say, to get healthcare, and unfortunately came back and it spread quite a bit in a closed-knit community. So I think they're trying to look at equity, but that's why I do think in Canada that realistically, people probably won't be vaccinated until, for the regular public, say someone of age 55, realistically in Canada probably won't even see the vaccine if they're not in a really high risk group, like a healthcare provider or first on the scene or something. They probably won't see it till late fall, unfortunately, but that still means in this year, we hope to get a lot of people vaccinated and that our supply and demand is figured out.
Well, Janet, if anything else, you made me feel young by saying I'll have to wait till the fall. Thank you. So I have a number of questions about, should people be looking to get a certain vaccine, and could there be different side effects depending on the vaccine? Are they best off getting the vaccine that's offered as soon as they can? What should they be? And the second question related to that is, should they try to get a different vaccine for the second one to have a different profile, or does it matter if they get a second vaccine? We've got both sides of that question coming forward. So, does it matter? Should they get the vaccine they can? Should they shop for one? And should they mix and match? What do people think?
So I can speak to those things a little bit. I mean, as I think maybe it was Janet who said this earlier. I mean, you're not going to get a choice, basically, not in the early stages anyway. The vaccines that are offered will be the ones you get. There is strong advice, although based on no evidence, but I think probably just common sense, that the vaccine should not be mixed. So if you get the first shot with AstraZeneca, you don't want to get a second shot from anyone else. So if it's a 2-shot regimens, you just stick to what you've been given. And frankly, nobody will be offered the first shot of one and the second shot of another. So that's unlikely to happen. I saw another question in there about, what do people think about the Johnson & Johnson vaccine? It's we're in a somewhat luxurious position, as Janet said earlier on, because of the fact that the two leading vaccines demonstrated such high levels of efficacy up in the 90s, which is, really very impressive given the short time frame that these things were developed in. And if you think about influenza, annual influenza is sort of 40 to 60% effective, although there's a little bit of gambling going on there about which are going to be the dominant strains. So Johnson & Johnson data, I think, comes back at about just over 70% effective. And you may remember that one of the early trials, I think it was with Pfizer, showed 60%, but then there was another that was up in the 90s. I mean, there is heterogeneity, i.e. variability in trials in the patients who are recruited, et cetera, et cetera. So 70% in this current context sounds bad, but it's actually still very good for a vaccine. So I think Johnson & Johnson will be a good vaccine to get as well. Maureen was talking about risk-benefit ratio, and we mustn't lose sight of the fact that the most critical sort of almost binary outcome in all of this is death, survival. So severe disease and death, and as Janet said, age is the leading sort of risk factor. And getting one of these vaccines, none of the vaccines so far, nobody who's received either of the Moderna or the Pfizer has died, basically. So, not only are these vaccines good at stopping spread, preventing infection, but even if you get infected when you've had one of these vaccines, you do have, measurable immunity, which is a benefit, and this is going to protect you from the most severe outcomes. So I think that's the strongest reason to go ahead and get a shot, is that, when it comes down to, absolute brass tacks, you want to protect yourself from a severe episode or death. And I think all of these vaccines are going to do that pretty effectively.
And that's good advice. I mean, one important thing to think about too as you're going forward, and this has been mentioned a few times, is where to get your information. So we've put the link up to the American College of Rheumatology recommendations. I think that John and Lacey may have sent around the Canadian recommendations. There's the question and answer, Scleroderma Foundation. But beware, more and more of the news make their money by creating drama, right? And even there was something in CBC last week that said, big flaring headline, healthcare worker was vaccinated and got COVID. Well, as Mark was saying, well, of course someone did. You're giving percentage of effectiveness. So some people get vaccinated will get the condition, but most of us who get vaccinated won't. And that's the big thing as we develop herd immunity and go forward. We kind of beware of some of these dramatic headlines that put things forward like that and forget the basic evidence. It's obvious. Of course someone got it. There's more of them out there too. It's not just that person who got her picture in the CBC. So go back, keep in mind what your good source of information are, and go back to those sources. Question here about advocacy. It doesn't sound to me from what people are saying like there's much of a chance of advocate for changing the distribution of these by to autoimmunity and so forth, but there are having a number of questions about whether there is a role for patients and patient organizations to advocate to get some of these rules changed for distribution. What do people think? Maybe Maureen or John or others.
I think the time frame it takes to exert political influence on these decisions will make it pretty much a moot point. You can't pick up a phone or drop down to Queen's Park and advocate to say this is what we need, or we're in Ottawa. It doesn't work that way. It's a long, tedious process to try and influence decisions that are being made. And the problem is that when you discuss, there's so many cancer patients on severe autoimmune conditions, whether they at a point maybe after 65 decide that they're going to give priority to people who have other issues who maybe should move up the line, and because the higher likelihood of bad outcomes for them, that's a political decision that would make sense to me because of the cost of hospitalization. So when you get through that upper tier of most at risk of bad outcomes, that there may be a decision tree at that point to bump patients with issues then. But I think certainly we'd be happy to lend our voices to it at that point, because one of the things that stands out is there is this sort of a shared clinical features, if I can use that word, between scleroderma and COVID. It attacks the lungs, it's fibrotic, it's all these things. Well, when those are already sort of baseline situations for us and you do get COVID, that would be obviously exacerbating pre-existing conditions, which is likely why the outcomes for our patient group isn't ideal.
I think
so there is an argument to have, but I don't know that in the short run we would be able to move that far. I think until we've got at least everybody over 65 done, they will be tone deaf. And they're so busy right now that advocacy efforts are not appreciated.
I think advocacy that's very closely linked to the professional organizations like the American College of Rheumatology or the Canadian, because I think the policymakers will listen to data. And if there is good data, objective data, we're not trying to jump the line. We have strong evidence that certain subsets of patients really are at a higher risk, I think that will carry some weight. Of course, like you said, it's a very, very fast moving thing, and these lobbying efforts usually are much more slow. But I think the professional organizations are, working very, very hard on making sure that patient populations that really should get vaccinated do try to get to the front of the line.
Great, thank you. So there are a couple of questions came in prior, in the last few days about research. So a couple people want to know, someone who had received both doses of the Moderna vaccine, had a fever, and wanted to know if we're doing any research on side effects among people who have with scleroderma who are getting the vaccine. And the second question related to that, I'll come back to that in just a second. The second relates to, are there any studies planned to assess immune response to the vaccine, such as with antibody testing? Now, the first one, we have colleagues from Cornell, Robert Spira, and some of his others who are actually going to use the SPIN cohort to begin to try to look at side effects. The benefit of that is we assess a large number of people every 3 months, so 1,500 people. The downside of our cohort is we don't have up-to-date medical information, biological, so we'll be getting reports of what people are experiencing without some of the the biological data that might be ideal to have. And I don't know if anyone's doing other studies on side effects, or if people are looking at immune responses anywhere out there. Do any of you know?
Right. So there was a grant applied for, I think successfully, that McGill with Sasha Bernatsky and others, and this is throughout Canada, are trying to look at response. They're trying to look at two things, and this is for inflammatory rheumatic diseases. So it's not scleroderma in particular, but they're trying to look at disease safety. So do you flare or not, by validated things, and kind of spreading it throughout the cohorts or the registries in Canada, number one. And number two, also looking at, would immune response be what would be expected compared to age and sex match controls, so that you can kind of look. And those studies, in honesty, we won't have that kind of data for 2 or 3 years, because you got to wait and look and collect serum over time. However, we will understand, because at some point, I'm sure we're going to need a booster or something, or a new vaccine if there's a lot of mutations occurring over time. So that kind of data will help us for later, but not for this year.
Great, thank you.
Brett,
Yeah, go ahead,
like
Mark.
there's another call for applications right now that certainly the Grand We groups from McMaster will be applying for. So that's from the Canadian Vaccine Surveillance Reference Group, combined with the COVID-19 Immunity Task Force and the Public Health Agency of Canada. So they're setting money aside specifically to look at vaccine responses in a broad swath of patients who are on immunosuppressive therapies, biologics, DMARDs, etc. So, gastroenterology, respirology, rheumatology, all of those kinds of patients. So there's certainly money that's being set aside. We're hoping that we're going to get some of it. There is research looking into vaccine effectiveness for sure.
Great. So Mark, I have another question out here. Maybe you can answer. After someone with scleroderma gets both rounds of a vaccination, and their family and friends have also been vaccinated, does that change how safe the person has to be out there in the community? Or in other words, can they what activities are safe? Or do they still need to take precautions after they've been vaccinating people close to them?
Yeah, they have to take precautions. I mean, the advice is that, even though you've had the vaccination, both shots, you should adopt all of the same strategies as anybody else who has not had the infection, has not had the vaccination. And there are a number of reasons for that. One is this business about, the efficacy of the vaccine. So a 95% efficacious vaccine is fantastic, but it still means that, 5 people in 100 were not protected from the infection. As I said earlier, and we discussed, there is evidence of people who get reinfected, maybe with a slightly different strain. So the point is, you can be vaccinated and you can still carry the virus around. You won't develop such severe disease. Probably you won't even notice it if you do, but you can still spread. You'll probably spread for a shorter period of time, but you can still shed virus. So you know, the responsible thing to do until we get right through to the other end of all of this is to behave as though you have not had the vaccine. But you know, rest assured that you are protected and you're much less likely to spread it around.
Great, thanks. You know, in the news lately, there's been quite a bit about mutations of the vaccine. You know, I know in Quebec, our numbers are way down, but everyone's on pins and needles just because of this, and as you know, seeing what's going to happen next. So there's a question: what do we know about the vaccines and how the vaccines might work, given the variety of mutations that are out there and coming to Canada or in Canada and spreading?
So there's some evidence that, you know, some of the frontline vaccines are not as efficacious against some of these variants. There's some data from the AstraZeneca vaccine that suggests it doesn't work quite as well with the South African variant. I mean, you know, this is evolution in action, and this is what happens with all infectious diseases. They change with time. These are not thinking organisms. These are just random events. Mutations occur.
Mm-hmm.
And if a mutation leads to a survival advantage for an organism, then that particular variant will blossom. And so, you know, by introducing the vaccines, et cetera, we're dealing with the majority of these viruses, but those that mutate sufficiently to escape the immune response that is generated from the vaccine or from a natural infection, those will ultimately prevail. And you know, one of the important questions is, well, how long is it going to be before enough mutations have occurred to create a completely different virus that the current vaccines won't cover? And you know, the answer to that is, well, we don't know. But you could reasonably look to other infections that we know a lot about, like influenza. And we know that, you know, similar to coronaviruses, there are secondary hosts like, you know, birds and other animals, pigs, what have you. Same here with bats and various other mammals. So, and we also know, for example, that, you know, mink farms got infected and then that jumped back into humans. So this thing moves around. It's going to change, and there will be most likely new variants. Sorry about the phone. New variants in the background that will, in time, you know, represent a problem for these current vaccines. But the point is, you know, we will be a long way down the road by the time that happens, and there are lots of other vaccines coming up behind that are targeting many more of the proteins that the virus makes. So, you know, as I said at the end of my slides, you know, it is a slight weakness that these early viruses have vaccines have just focused on the spike protein. But the point is, it's doing the job. It's getting us right the way down the line, giving us the herd immunity. And the other vaccines that come online after that may then need to be applied to deal with variants down the line. But right now, there's no suggestion, even though some of these viruses have mutated quite a lot, there's no suggestion that there's any risk, any serious risk with the frontline vaccines.
Great, thank you. I think we're scheduled for an hour. We still have a few more questions. I'm happy to go through those questions with people if we have another 5 minutes or so, but I know people on the panel may have to go. And should we continue? Is that okay with people? Okay. Okay, great. There's a question about, we talked a little bit about short-term ramifications, about flares and stopping medications. There's a question about, you know, whether RNA vaccines might have long-term ramifications for disease treatments. Is there any reason to be concerned about long-term ramifications for one's treatments if they take the vaccines?
No, I can't think of any.
Okay.
And I would agree, again, based on so many different vaccines of so many preventable diseases that are already out, measles, mumps, rubella, the chickenpox or the zoster virus vaccine, pneumococcal, 2 different vaccines out that are widely used in Canada, often in unison because they then cover off a lot of pneumococcal or strep pneumonia. And we don't see, at least on all these various other vaccines, and all these childhood vaccines are probably double the amount as when my first kids were little to now like a first grandkid. There's far more vaccines being given, and we're not seeing an explosion explosion of new autoimmune or worsening of other conditions, because although they wouldn't be looked at from cause and effect, we have a lot of population data. So I don't think there's something like, oh my goodness, it would do XYZ to your systemic sclerosis condition 2 years later. Like that just isn't something we would think about. I don't know, Mark, if you have any other way of looking at it.
No, I would agree with that. I mean, there's, as you say, there's a lot of data and a lot of vaccines, and not much evidence that that disease scores get worse.
We had a question come in about people in their 30s getting vaccinated and when that might happen. I think we're half safe to say that's going to be into the next year. I don't know that we know much more than that at this point. One question came in about medications after we'd been through the discussion, so maybe I can ask that just in case we didn't get to them or they weren't here. But are CellCept and Tramadol safe to take with a vaccine?
So for Tramadol, that's a pain medicine, no problem at all. For CellCept, I think you're going to get different opinions, and that's all right to get different opinions. Currently, because the ACR guidelines literally just came out this week, I think, I was telling patients prior on CellCept that I saw no reason to hold it because the half-life of biologically how it's slightly altering your immune system won't change with holding it, say, for a week after the first dose or a week after the second dose. And the fear for me is, especially because the vaccines are baseline and 3 weeks later or baseline and 4 weeks later, if you're holding for 2 weeks, you take it for a week again, you hold it for 2 weeks. That means in 5 weeks, if all is going well, you could be off your drug. And for some people, that's enough to make a flare. And for many people, it's not enough to make a flare. So I think that the answer is you could use your CellCept, and the other answer is, well, you could hold it as well. And I think both answers, more will be known over time. And recommendations already, the Canadian Rheumatology Association recommendations, every version that comes out has a date on it because they've already changed, where we are even more liberal. The first were advocacy against to advocate to the Canadian Public Health Agency, saying that in the sense of fairness and justice, our patients should not be refused. And if anyone's gotten the Pfizer vaccine, and probably the other one as well, the Moderna, you actually had to write down your meds and what diseases you had. And so people were being denied as healthcare workers who, say, had rheumatoid arthritis and were on just methotrexate. And we had to write notes to get them vaccinated because they were in high risk areas like working in long-term care. So as of, for instance, the first ones were more about advocacy. The second ones were more, I guess, thought out for our Canadian Rheumatology Association guidelines that our patients, should be offered the vaccine. We think that looking at the other data that it should be effective, if not highly effective, at least somewhat effective, and that they should be as safe as for other people. So that's kind of how we have worded them more recently.
Great, thank you. So a couple of questions that aren't vaccine related directly, but more related to the experience of people with scleroderma and COVID, and before we wrap up. Now that time's passed, do we have any insight into the outcomes or the people with scleroderma who have gotten COVID, how they're faring? And what should a scleroderma patient do if they get COVID-19? Should they do anything differently than anybody else?
Oh, I can unmute. So there's the Rheumatology Global Alliance, and it's multi-country and including Canada. So we're a site, and there's multiple sites in Canada, but US and all over the world. And every time someone has COVID with a rheumatic disease, when we find out, we have our IRB or ethics approval to do a chart audit because this is something that it's for the common good of our patients. And right now, we don't have enough systemic sclerosis patients for me to tell you much, but at least anecdotally, and also looking at lupus, looking at rheumatoid arthritis, ankylosing spondylitis, in general, so it's not specific, but in general, they seem to fare about as well as other people their age with other comorbidities that are the same. So if you had bad heart or obstructive lung disease, and maybe then that means interstitial lung disease as well, or shortness of breath in your heart because of pulmonary hypertension, the more problems you have, the less likely you'll do well, but age coronary artery disease, obstructive lung disease, diabetes, high weight, and high blood pressure always seem to be major and minor risk factors, even across our patients. And for hospitalizations in rheumatoid arthritis, which is far more common, 1 in 100 people have RA in Canada, it looks like hospitalizations are in some studies about the same as other people without rheumatoid, age matched and everything. And one study, though, there was more need for artificial help to help the person breathe, so being on the ventilator. And there was also longer hospital stay, but mortality was not numerically or statistically increased. So it looks like our patients overall do about as well as the rest. So far, so good. However, you know, things will change and mutate, and that's why we're all on guard. But I think if anything, it might help you to justify why you're social distancing, not going out, staying home, all that, but maybe to be reassured that you still should, for your own mental health, go for a walk. You should do your exercise. You should be maybe cautious, but not overcautious. It's always a fine line, being now almost 1 year into this. It's very stressful for people, particularly for patients living with an illness with a big unknown.
Thanks. Any idea, as a last question, I think, any idea when people with scleroderma may behave normally and not behave as if we have not had the vaccine? So when are we going to get back to normal? I think that we'll have to wait and see on that one. There's going to be when I think the rates of transmission, I would imagine, get down to the point where they're much lower than they are now, or we'll be out of the woods.
And I
Any
think
other
it's
thoughts on
country
that?
specific too, right? In Australia, there's a lot of, they have zero tolerance. So they'll lock down, severely lock down, and they'll lock down until numbers go into the single digits, like Melbourne. But then with great strict measures, people are allowed to go to wedding showers and things like that now, and to have open worship, whereas, you know, we've been locked down for a long time, right? So I think in various jurisdictions, rules will change. They are a moving target. And plus, we get more knowledge over time about how contagious one of the strains that's certainly throughout Canada right now, the UK variant strain, seems to be very highly infectious, or more highly contagious than the past COVID strain. And it too, all these strains, you know, things will come and go and blip.
Sorry about this. We're shopping our new puppy around, and it's fallen to me now. We were confused about herd immunity. We thought that if we got a third dog and begin to put a dog herd together, we could be immune, but apparently it doesn't work like that. But she does pee a lot, and now it's been passed to me. So I apologize. My family is not impressed by the fact that I have this role. Anyway, so before we close, this has been a great panel. And thanks to everybody for all their comments. Do the panelists have anything they'd like to say before we close up for the day?
I'd like to jump in, Brett, and just say thank you to all the panelists for joining us. I think for the people that are here, that watching and listening, they received a wealth of information from very intelligent and very supportive doctors with the scleroderma community. For the people listening and watching, I just wanted to share with you, it was one email, and right away the response was, sign me up, I'll be there, I want to help. And that's the type of people that are here on this panel, and they're committed to the scleroderma community, and we're so grateful to have them. So I want to thank all of them for being here. Of course, Brett, you as the moderator helps things go so smoothly and so well. So thank you always for your support and everything that you do for the scleroderma community. And before I just go back to turn it over to Brett to say closing remarks, just remind everyone that the information series will continue. And our friends in Alberta and Saskatchewan are hosting the next one in March. It will be on March the 23rd. And they're going to have Dr. Martin Hogan on to talk about dental, if you're interested in joining on March 23rd. So with that, I'll turn it back to Brett.
Well, that's all. I think, John, I really want to thank you and Lacey and everyone at the Scleroderma Society of Ontario. I think one of the patients in Canada are super fortunate to have such great organizations to support them. I mean, of course, the organizations are made of the patients. So it really speaks highly of our community in Canada. All people have been able to achieve by coming together, and you guys represent that. So it's another great event, and thank you. Thanks to Mark and John and Janet for coming and doing this. Everyone here, we've had the benefit of some of the top advice in the world, and thanks to all of you. I know how busy you are, and for making the time to do this. So thank you.
And I did forget to say that it has been recorded, and it'll be on Scleroderma Canada's website and Scleroderma Society of Ontario's website in the next couple of days for people who want to pass it along.
Yeah.
Thank you.
Thank you, everyone.
Thanks, everyone.
Bye.
Thanks a lot.
Take care.